So, welcome you all to this session, this plenary session 2B, at how public health and primary health care can work together in order to really achieve health equity and well-being and development. My name is Karina Kostongs, and I'm the director of which is a European partnership of national public health. More than 60 organizations are part of that. We work towards health equity and well-being. And I'm co-moderating this plenary session together with Tony.
Yes, thank you very much, Caroline. So my name is Tony Dalil. I'm advisor for primary health care at the WHO Center for Primary. We are based in Almaty, so in Kazakhstan, but we give support to 53 countries from the WHO Union.
Thanks, Tony. Yeah, so primary health in combination with public health and health promotion and disease prevention, potential to tackle health inequalities and determinants of health. In this session, we discuss this. We're going to look what is the evidence and can we best invest in primary health care in combination with public health and health promotion, disease prevention, and what approaches are out there. Social prescribing is, I think, a very nice approach. Same for how we can best work with from more disadvantaged areas and work with the social determinants. How can we address that within primary health care? And these are important for us to address today. And we are delighted to have a panel here with us, where we look into their approaches to equity in the development of their primary healthcare structure, and we will listen to their stories later.
And we would like to bring into these discussions evidence on how primary health care and public health are successfully working together. And another thing that today has been said in the opening session, that the primary health is the cornerstone of the universal health coverage. But despite one of the messages we would like to send here is that many countries, they still invest, or there is a slowing in primary health care and public health care, and this is something that we'll discussion here too. And another thing that's important is the consultation, collaboration between different stakeholders beyond care and public health, and this will be brought up here as well. And now, I would like to give to Awad Mataria. Awad Mataria, Director of Health Systems from the Eastern Division of the WHO. So, Awad, I'm going to give the floor.
Thank you very much. Thank you. Well, thank you very much, Tony. It's a great pleasure to be here. Thank you very much for the invitation, for making me to be part of this important session. We had this plenary this morning, a lot of introduction, a lot of experience. And when I was asked to give some spotlights, some introductory remarks, and parallel session, I tried to look at the subject that was given to this session. And you can see that there are many in it. We are talking about public health, we are talking about primary health care, equity, and we are talking about development. So my task was to see different concepts are interlinked. So I come from health system background, and I always try to be very clear about concepts and their interlinkages. Not really clear about the conceptualization of the matter, will not be able to properly move on in implementation in achieving what we want to achieve. My way of trying to link these four keywords together was to, and the fifth one is health system. So for me, health system is what the concept of primary health care, concept of universal health coverage, different inputs in terms of service delivery, and so on and so forth. And as WHO and as different partners working in the area of health, we oftentimes go back to the World Health Report 2000, has provided a clear definition of what a health system is about. And the health system is about all institutions, about all activities, for primary intent is to maintain, to promote, and to restore. That is very, very, very important. So we see that health system is really goes into helping countries, helping individuals and societies their health. But also we are cognizant that health system is a source and is a facilitator for other types of including economic development and social development. So we system, for instance, contribute with many economic outputs, activities, services that are being provided, but also commodities that are, and that is a source of economic development. So that's part of the development. We also know that health system, well-functioning health system, contribute financial protection. It is one of the three goals of the health system, right? And with protection, we are promoting an economic development agenda. Because not fall into poverty or not poor, they can continue to spend, they can continue economic development. But also health system contribute to social cohesion, which relates very strongly to the agenda of political stability, which is very important in the region where I'm serving. So I come from the Eastern Mediterranean region. Just myself, I'm Palestinian, and we see that how the health system play a role in social stability, in social cohesion in any. But also the World Health Report provided us with some information about how to advance the 3 goals I referred to: responsiveness and promoting financial protection. It also provided this idea that health systems are, or sense that they keep evolving. So our understanding of health systems has been changing over time, right? When in 2000 we were talking about, which are very much related to the health sector per se. The pandemic has really been a wake-up call for all of us, and has shown that only important for equity, for social development, but health security, and to see how health system can really contribute with the agenda. And since then, we are trying to bring these dual goals of unity, the equity agenda, along with the health security agenda by building health system. So if we want to have resilient and equitable health system, agenda now and the learning from the pandemic is that we need to invest in what we call essential public health functions. Primary care provision of services, I don't want to miss on the 3 components: primary care functions, community engagement, and multisectorality. But the essential public health has been for long missed and has not been taken care of our health system agenda. So when even countries, when they were developing national plans, we didn't usually refer to surveillance, to promote emergency preparedness and response. We are looking at them as different systems of the health system. So moving forward, if we want to have a resilient system, we need to bring in the public health agenda, the essential public health functions, the primary health care, to move towards the dual goals of universal health coverage and health security. How would that relate to development? I explained from an economic point of view. What remains for me is to link that with the equity agenda. That is coming from the financial protection agenda, but also if we take health, by definition, for economists, are common goods. These cannot deprive anyone from once you are providing them. The characteristics of non-excludability and the characteristics, so you include everyone and you will not exclude anyone. So by definition, guaranteeing the equity agenda, which is very important for our future health system, and for long focusing on efficiency at the account of equity, and they will have a development agenda. So I hope that these 4 keywords, while might seem similar but also different, I managed to bring some into them. What we want is to have equitable, resilient health system, contribute to universal health coverage and health security that would result in economic stability, and so on and so forth. And thank you very much for this opportunity. Looking forward to discussion.
Thank you a lot. And now let's see if a video, if it's possible. There is a video about the health train in Kazakhstan, a health train that moves, as you know and has been told, Kazakhstan, 9th biggest country in the world. So the distances and the remote areas that can be here. And the Ministry of Health, they promoted to train to access to the people who live in the most remote to provide high quality services. So let's see if the video is ready. Let's watch it.
Бәрі біледі, естіді, денсаулық пойызын келетін. Қуанып жатыр үлкен кісілер. Облыс орталықтарына бара алмайды, ауданға бара алмайды, қашық қой, шалғай ауыл ғой мынау.
Лекарство пропьете и ничего не будет болеть. Ладно, Саша.
Медицинский поезд в этом году начал курсирование. Общая наша протяженность километра 19 тысяч километров.
График поезда для того, чтобы охватить максимально все отдаленные регионы. Или не всегда имеют возможность получить медицинскую помощь.
Здесь у нас начинается регистратура. Кабинет кардиолога, установленный ЭКГ, лаборатория, кабинет окулиста. Здесь у нас фотография.
Фельдшер мамандығын аяқтап, осында жұмыс жасап жатырмын. Фельдшер қызметінде. Өзіме ұнайды жұмыс. Осында жұмыс жасап жүрмін. 2046 адам бар жалпы. Осы неде сәйдесте. Көмектесіп біреудің саң өзің жақсы сезімде боласың. Ал наоборот алмай асқынып кеткен жағдай болса, или жаңа жол апаты соның әсерінен адам қайтыс болған жағдайда өзің мұңайып қаласың. Біздегі қазір барлық учеттарда жалпы халықтың барлығына түсіндіріліп, осы денсаулық пойыз алуға, одан жаңа анализдерін тапсырып, флюор түсуге жіберілді.
Doctor must contribute. Pick up a suitcase like this one. They'll follow scheduled routine. Between 2010 and 2019, 80,000 inhabitants in remote areas of Kazakhstan. The health train.
Now we enter to the meat of the session. This is time to introduce the panelists. Caroline, please.
Thanks. Slovenia, I'm honored to introduce you Dangele Jankauskin, Minister of Health. From Slovenia, we have Vesna Bies, Director of the International Office of WHO at the Ministry of in Slovenia. I would like to introduce Hussein Farshadi, Minister for Public Health of the Ministry of Health and Medical Education. From Sri Lanka, we have Suraya from he's Deputy Director General. And from Brazil, we have Felipe Proenço, Primary Healthcare Adjunct Secretary of the Ministry of Health. And Milka Savic, she's Director General of the European Public Health Alliance. So we'll now do a deep dive and to see how public health and health equity development of your health systems. And I would like to start with Lithuania, Jankowski.
A policymaker from the small country near the Baltic Sea. We have 8 million inhabitants, and we developed a national health system for 30 years because we got since that. And developing a national system and also primary health care, we are using mixed healthcare systems. In that development, in my mind, is very important for us as policymakers to distinguish stage of your society development you are. In my mind, here in the country, our society is developing to the democracy by all stages. It is going, so why stakeholders' involvement is one of the issues that we face at the moment at that stage. Because the people want to participate in decision-making, people are very keen to in all decisions that we are facing. Healthcare in Lithuania is under the of municipalities. We have very great inequalities in municipalities, and also we develop public and private. So 2/3 of providers in private and 1/3 is public. And those providers, they in the municipalities where they have to be responsible for basic package of services that their population has to get. So we need to create for municipalities could have the possibility to coordinate, to be responsible for that package of services. So we have used two types of. The first one is the team for general practitioners. We introduce for one that serves for 1,500 inhabitants, 2 nurses, 1 case manager, 1 also kinesiotherapist, and some registration responsible person. So in order could be multidisciplinary, medical side, but from another social sides that they have the system. So this is the one instrument. The second instrument, we introduced networking. Networking, I mean, we are creating community health centers, and they could 2 types. One could be that they structural one, when they merge in small municipalities, several institutions for primary care mental health, primary health care laboratories or primary health care centers. Also hospitals, small hospitals we have for long-term care, small hospitals, and also for therapy profile, very small hospitals in the rural areas. So this would be structural networking. Networking, it is functional networking, where everybody to make the agreements between all institutions. They could stay now in the same legal entities, but they have to have collaboration agreement, and that means they have to meet every quarter at least, or even sometimes more times, and they could discuss what they face. And they face the problems in prophylaxis, in book organization, whatever. So the cooperation is also a little bit regular form that we provide financing. We meant structural investment funds. We say that all funds are related. And if you are participating, what is, of course, you get money for development. And also there is from Health Insurance Fund also the financing, the bonus for those community health centers. So I think that stakeholders' involvement in that field then give them incentives also to participate, because there are different maturity of those stakeholders, NGOs, very different, and to talk with them is quite difficult. You have to have certain incentives also to them organize things. Thank you.
Thanks a lot. Very, I say, and to see how you have used European Union to give incentives for the networking, and very nice to see that primarily just the GP, but really multidisciplinary teams working at this level, and how you provide municipalities with instruments to others and other sectors on board. I think it's a really inspiring example, and thanks for that.
So, going to introduce Vesna Petric. I've had to work very closely, and I'm still working very closely with Vesna and Slovenia as well. And I feel a little bit part of my country as well, because I go there often, even with my family. Really lovely country. And what's striking about Slovenia is one of the first countries to introduce the concept of community centers in the perspective community centers promoting public health, times the collaboration, and this is one of the things that we want to bring, collaboration between primary health care and public health. I think it excels on that. But one of the things, and but the question...
That, okay, our health system, public health system, is 100 years old. And we had a first primary center almost 100 years ago. So we have a long tradition of institutions, and they were working fine with each other in public health with individual approach. So population approach with individual approach. Our advantage, because we knew how to do this experience from before. So we said, let's introduce prevention in, for example, to be very practical, if you patient services in the primary health care, then you need to, with legislation, that does something in tobacco that is, courageous, and we did introduce a lot of tobacco control. We were among the first that introduced banking in all the restaurants, but we also have free of charge services in primary health care. This is when I say combine these two, it's important. Now, we decided to establish health education centers in our health. And it was meant that these services provided from multidisciplinary team, and we would offer through these services, cessation, counseling on nutrition, and so on. After 10, 15 years, when evaluating what we realized that people attending these services in primary of charge were not the ones we were after, not the vulnerable. These were women in their early retirement very often. That already did take care of their health, but even better. So we realized that we actually getting to the most vulnerable. And we didn't stop there. We did, I'm telling you, millions. We are 2 million population, but we in millions of euros to get it right. And piloted, were now called not health education center, but health promoters were established to reach out to the community, in the community with NGOs, with local administration, with social services, with schools, employment, to get to the vulnerable groups, to assess their needs, and then better address their needs in the community. Speaking of social society, so NGO community, I have to say that, you know, they have potential, and we understood that if we want this potential, we have to invest in NGOs. Speaking in health, and I'm speaking of NGOs that have the use and the same aims to contribute to health. Not but those NGOs that are after social, you know, and health aims. So we do invest, I don't see in other countries, but from public resources, through public tenders, the NGOs in Slovenia working in their finance. With this, we ensure some continuity. Then we can, of course, work with them appropriately. But it's not, we have to invest more. We have to ensure that civil society, organized patients, organized youth, this is what I'm talking about, are working with, are being trained, are being evaluated for the impact and the efficiency also, because they are using pubs here. You know, so that is crucial. We are very often saying, let's, you know, involve civil society, let's have social participation. But what are we talking about here? Talking of working together on the ground. It's not only this. And here we are speaking of social participation. Very important that we see are young people, organized young people. It is because they can help us reach out, right, in areas where we actually do not know yet to deal with. And this is commercial determinants, mission that is on the web everywhere. How can we address this? Literacy among young people. Are we going to introduce it in school? Wait for decades that we get it right, because it's not yet in school, many generations to go. And we see that there is youth, organized youth. To conclude, Slovenia is very ambitious here because we see that there are others also investing in this kind of social participation. We are aiming to have a resolution at the level of to be adopted next year at the World Health Assembly. To Ireland, Norway, Brazil, Tunis, France, some other countries, we are working on the text of this resolution because we want WHO to engage more, also work with civil society in the same way in our country, to empower them, to train them, to evaluate, to look at the impact and report on this. That is the role, as a role for the World Health Organization. Thank you very much.
So thank you. Thank you very much, Vesna, for bringing these strong power messages to us. And I think you've included concepts here. So the youth, that it's one of the conference as well. And then social participation is in many developments of primary healthcare and public healthcare collaboration. I pass to Caroline now.
Thanks, Tony. Let's move now to Iran and to the Deputy Minister of Public Health, Dr. Hussein Farshidi. In Iran, healthcare is very well developed in rural areas. Cities, primary healthcare is not yet reaching. And since several months, the government is into how to strengthen primary healthcare in cities. So to hear about it, and also if you manage to include, let's say, prevention and forges links with other actors and how that's included. Thank you.
Thank you, Karina. As you mentioned, there are a lot to be here from primary health care. As we know, it's a long journey from 78 from Almaty. So what time from primary health care and what we are facing now, a lot of change being happen, and we have to do a lot of our actions to get better. Mentioned today morning that deal with primary health care, dealing with good standard. It is an action, and if we're not going to aware of it, maybe it become fragile and something opposite what we are looking for. In Iran, we have a good potential. Today morning, our friends mentioned every country is different. they got different potential. They have to work on their own potentials. No one rule for all countries. In my country, we have integration between education and health services. So me and the education, we are in the same apartment, same build together, we are working together. So what I need in I, as order, gives to the Deputy of Education, and they're going to educate persons, educate health providers. I need, as you mentioned, and really, we had a good network in rural area, and maybe more than 95% there in rural area, they're covered by the healthcare system. But my challenge is in the last 10 years, the movement of people from rural areas, where they go to big cities, marginal areas, they don't have what we are going to have. They don't have that we are saying about. Here's this problem. So in last 6 months, last April, we have a new called family health and referral system. This family health and the cornerstone of this program to the ratio of people that connected to health providers. In rural areas, we have health houses with behaviors that they covers about near 1/3. They do their works actively. In the urban areas, I don't have the active follow. So by health providers that they have some real they have to have a good communication population. They could translate what was mentioned about the health literacy to make the services and change the service. Now we are giving as passive services to active services. So the target now is to make base connection between society and this to people, to encourage them and to have these services. Our strategy is now to increase, to expand the society and people's health literacy, working on it. Health providers, are they enough to do this? Our community, our media is enough to do this? So we have the volunteer systems, 20,000 volunteers that they are connected to, and these health providers. The health providers, they, as I mentioned, with the Deputy of Health and Deputy of Education, in training systems that gives new abilities to this health provider and connect to population and to increase this health literacy. So what we want from these people, we want to make a demand. They ask us that we need to control to test how we have diabetes or not. Until this item is not active, there are things we can do, but the target is not active. Now, a lot of people know that hypertension is important. I have 85 million population. Serve them. 60 million of them are in the areas. About 30% of people, 30 years, they have hypertension. How many of them are now diagnosed or treated or being controlled? 20. Not just to say hypertension is important. No, okay, I have hypertension. To be out, to be controlled. If I have 70 patients, then I can imagine that 10 years or 20 years, what will be the mortality of cardiac or NCDs. So this new program is from last 6 months going on, and I hope by next 6 they're going to have a good result from it. At this time, these are people. 93 of a small covers by this program.
Thanks a lot.
Thank you.
Sorry. It's so great to hear that you work so close with the education sector, and this is in the medical training, but also by boosting health literacy and working through family health centers. Yes?
Ministry of Health Education. Our ministry is this. Two
Okay,
ministries.
okay, it is, of course, of course. Okay, fantastic. Thanks a lot, Tony.
Thank you very much. And to ask a question to Garuzinia Iya, and from Sri Lanka. We know that Sri Lanka is a good example and as a very effective primary health care. One thing that maybe you are going to reinforce is about the free of services in Sri Lanka, a very broad services provided at primary health care. So I've been to Sri Lanka, the broad basket of services you provide there. At the same time, very well-trained family doctors as well, and of healthcare professionals. And you have achieved very high levels of equity. And my question is, we know the current situation in Sri Lanka. How can you maintain this you have achieved in the future? So.
Yes, actually in Sri Lanka health system, if we consider primary healthcare services, now more than 95 years old, our primary healthcare service. And I think compared to other countries, in Sri Lanka, healthcare system is a bit of change than other countries, that our healthcare services are free of charge. Curative services as well as the preventive services, everything free of charge. Is that services is customer-driven system. Person anywhere, anytime they can go for, they can select or hospital or whatever it is, they can select the patients. Boundaries, there is no limitations. They can go anywhere. So I think so far we have achieved very good in Sri Lanka. As you said, yes, I know how to run this system. Is the bit of, yes. What we believe is actually for system in Sri Lanka, we have a very high political. So they are giving the health. So government always allocate the amount of money to maintain the healthcare services. So with that, we are trying to get the maximum for our country. So far we achieved a lot of results. We have eliminated some diseases. We have eliminated some communicable diseases. And that is because of very good public health services in Sri Lanka. Mainly, we have understand that to invest there's a big amount of resources for the preventive health as well as the primary services. In that way, we can minimize the funding for the healthcare services because in the tertiary and care level, we have to pay huge amount. Treatment of the heart disease, there's a bypass surgery, very high. We have to invest a huge amount. So if prevent these diseases or detect early, we can prevent the unnecessary complications that invest in much and more for the primary services as well as the preventive care services. I would like to say for the maintenance of the equity, identifying the most vulnerable, especially in Sri Lanka. There are a lot of tea states, hill country region, and there are people who are working. We have separate medical centers for these states. They can reach they can take their medical center. And recently, we are appointing MBs, that most qualified doctors for these centers. In the same utilization also, we are going to increase that. The availability of these centers, that means earlier these hospitals, of course, they 8 a.m. to 4 p.m. in the only daytime. Now, increase that services time. So most of the hospitals, 95% of the hospitals, they are 24 hours or 6-7 days of the week. The night, the people who need that care services, they can get care services and get their services. And some hospitals, they are closing around 6 o'clock or 7 o'clock. In that way, we have increased the utilization of these services. In addition to that, we are identifying some vulnerability for the children who are under 5 years, most of more prone to have malnutrition. and some young people that can have diseases. We have given some targets for services professionals to achieve some targets. For one example, one medical center, they have to reach some amount of their population percentage is screening for the non-communicable disease like heart disease, or sometimes for the cervical cancers, breast and oral cancer, like that. They have to screen the recommended number of patients. Like that, trying to increase our productivity. And at the same time, in primary healthcare setting in Sri Lanka, each 10 kilometers distance, there are primary healthcare centers. Then anytime, within less than an hour, they can reach the primary healthcare centers. System as well as transport systems are good. So they can utilize our healthcare system. Thank you.
So thank you very much. Now I'm going to give the floor to Caroline to keep the...
Yes, thanks, and I'm delighted we now Brazil and to Philippe Proenzo. Brazil has actually very high quality primary health care, and you also have various innovative ways how to qualities. So tell us, what is the Brazilian recipe? And I'm particularly interested to see how you indeed reached difficult groups to reach in your country.
Thank you, Caroline. More than 5,000 municipalities. It's the complexity of developing a universal health system, as well as we look at the importance of primary in a context like this. The need for a universal health system is present in our Constitution for all and a duty of the state. Therefore, that the perspective of universality in the health paramount. We also understand that we have to work, once again, the role of primary health, and we also understand that we have to work the way, valuing local initiatives. Therefore, in the 90s, a community health program began in Brazil, and then the family health strategy, which is represented by primary health care teams, which are entered in municipalities, composed of a doctor, a nursing technician, and a community health agent. Over these almost 30 years of the family health strategy, there has gradually been greater adherence from municipalities. And with the induction of federal funding, we can the number of these teams, which today reach 5,000 in now municipalities in Brazil. Since Lula new administration, the prospect stated another 20,000 teams by 27, further expanding the population fit from having a team close to their home, and we were able to have greater access to the public health. This also includes the need to think about strategies the most vulnerable population. So we have teams that work with the prison population, homeless population, as well as teams that rural areas, in riverside areas, and in addition, we have a subsystem in the public health that also covers indigenous population. Our primary health care has based on the role of the community health agent, who is from the community, recognized as a leader by them, to work together with our team of family health. The monthly visits homes in their own territory, bringing this dimension of community work and prevention. In primary health care, we also have multi-teams, which there are several professionals, psychologists, nutritionists, and social workers. Our primary health care in Brazil is also marked by the participation of oral health through a program called Smiling. Furthermore, we have specific programs for the Amazon, where through boats and rivers we reach the most distant communities and actions, such as the number of doctor dislocations. These are then some of the Brazilian federal government initiatives, together with states and municipalities and the social participation, strengthening primary care. And once again, Brazil has a government that values as values public health. Therefore, an investment for the next year of almost $1 billion in the structure of health unit and more than $2 billion for the expansion of family health teams, oral health, the entire framework of primary care in Brazil. Thank you very much.
That's indeed a long recipe. I will highlight the key ingredients. Constitution, it's universal. You strengthen, you invest primary health care teams in the community, close to home, also to take care of the homeless, invest in communities, multidisciplinary, and investing in social participation. Really great. Thanks for that.
Thank you. Thank you. Panelists, from members from WHO, we are very proud in this moment. If you, we have 4 WHO regions represented, and this is what we wanted to achieve. So the different angles and the different, and then even if you go within a country, there are contextual issues in these countries, and big countries like Iran and like Brazil, but small countries as well. So we wanted to have this in representation of the variety of contexts that there are table. But now we have the privilege to have with us Sokolovic. Milke, you are the Director General of the European Public Health Alliance. We would like you to have an eagle view, so what you've seen and from your experience and what we are still missing. So this is the question.
Thank you.
Thank you.
Also, congratulations for putting such an amazing panel with such beautiful insights. We've heard about multidisciplinary approach, multi-stakeholder approach, constitutional approach, really wonderful learning for all of us here. Before I answer your question, let me just give you a little bit of my own lens so that you know the landscape that I'm coming from. So I leading advocacy public health alliance in Europe. What sets us apart from other public health NGO is our membership audiences. Our members are very versatile civil associations, from healthcare professionals over research organizations, patient groups, specific disease groups, and importantly, organizations that represent interests of the vulnerable population group. Doctors and nurses are not with us to talk to each other. They are with us to people and work with people. And that's the perspective that I'm coming. And needless to stress, health equity is our key objective. And again, answering your question, I have to do a little rewind, and just because of this that we live in. When you think of Almata Declaration from 1998, it was visionary, inspirational, beyond limits. And the best proof is that the Astana Declaration from 5 years ago did a vision. It was a modernization. It was a little bit of upscaling compared to the vision that was set 45. What I find shocking is that almost half a century, we are still fighting for health as the fundamental human right. How is that even possible? And the other thing for me is we are still investing in war and conflict instead of health, and I couldn't pass without noticing that. Thank you. Now these almost half a century with successes and victories, and we have spoken today about life expectancy, about maternal health, maternal and child health, about nutrition, immunization. Communicable are not the leading cause of death anymore. But we are facing challenges. We are facing non-communicable diseases, conflict, as I mentioned, economic uncertainties. And in these complex situations, we are all convinced here that the primary health care is the most equitable, most cost-effective approach to enhance people's health. But I would equitable health system approach. But there are factors outside of the health system that we need to work on because they play a critical role in shaping. And you know that I'm thinking of the determinants of health, and by that I mean the social, the environmental, the political, commercial determinants of health. If we are to survive and improve health, we actually need to focus more on prevention. I'm only talking about the primary prevention within the primary healthcare, but I'm talking about the primordial prevention, such that the non-medical factors that shape our lives are changed. And those factors are anything from the market, like tobacco, like alcohol, like food and beverages, all the way to air we breathe, to the built environments and natural environment, to transportation, and all of them are at the core of health. So what I think is missing is tackling health with bigger societal, economic and political perspective. And that is, again, a complex issue, and it will require complex solutions. There is no silver bullet. We can't, a snap of a finger. And I don't think that primary health care or public health or both of them together can tackle. For that, we really need, as Vesna was saying, stakeholders on board, and we need a systems approach. I think most importantly, we need political will, courage to put people over profit. I think we need to change. I mean, in that sense, it would be easy, but be easy. And I think from these rooms in this conference, every single one of us needs with an idea of health and public health advocacy on a whole new level. And that's what I would like to leave us with.
Thank you so much.
Yes, we are coming to this plenary session, and we've heard really amazing examples of our panelists, how investment in primary healthcare, so linking it with public health, with health promotion and prevention, and other assets that are there in the community to help health equity for all. I would now like to ask all the key panelists to come up with a few, because like 30 seconds per person, not much time. What is your key message to the audience? And I actually would like to start with Iran, with Hussein.
Thank you again, and really it was wonderful to learn from each other.
Yeah.
I just say this.
Fast.
To go for primary health care or any factors health, you have to find a stakeholder. You have to go to fight with the parliament members, to go to fight with the budgeting organization. You have to give messages to society and the people that are expert manner. Take them, talk with them, and bring them at your side, and then all together go to organizations, ask for anything else we need to improve our program.
Thank you. From Philippe Poinso.
As a final message, I would like to highlight health as a right for every human being. In fact, is what drove the Alma-Ata Declaration and what the world hopes to achieve by 2030 Global Development Goals. May we remain strong in this proposal.
Thank you. Milka.
Well, I guess I was already trying to give some strong messages. So back to the title of this session, which is Synergizing Primary Health Care. And the definitions of the two are many and some using. At the same time, the responsibilities of care and public health, primary health care and public health are really overlapping. So I think what we are going to see in the future is public health care instead of primary health care. I see one field attacking the challenges from the individual perspective.
Great, thank you. Vesna.
I'd like to conclude by saying trust is key. And when it's key, everybody will ask, yes, but how to create trust? You know how to create trust. You create it by working together. We were developing our primary prevention certainly like that. Ministry of Health, public primary health care working together, and then at the local civil society, local administration, healthcare center, promotion centers working together, working to create trust. See you in Tallinn to discuss further.
Thanks.
Listening to all of you, amazing. I was thinking that in 45 years, still talking about behavior change. And the teamwork, that is about stakeholders' involvement, that is about all our behavior that also requires sciences, because stakeholders also requires knowledge how to do that, to maturity of each of them. So I think we'll meet all together in another 40 years, talking about the same as milk.
Carol Singer.
Yes, I totally agree with our Director General what she said, that the human right, that everybody's, all the countries we have for our population health. That's our responsibility as a health. And I think WHO, UNICEF and other funding, they are very much supporting. So in future, don't know that sustainability will be a problem. So we should some kind of system to how to sustain this future, so that, as you said, I think better by the primordial system, how to prevent the diseases. Our social determinants, we have to identify the social determinants and those things, as example, tobacco, alcohol, their causes diseases, and nutrition. For in future, we have to give some priorities for these social determinants. That's my message.
So, just an applause. And I'd really like to thank you. It's been an amazing session. 4 regions all together, UNICEF involved, and I think this is an excellent example that each of us, we've got something to tell, especially for the population. So we've made a step forward from Astana 2018. Let's be positive. I think we've done it. And now I would like just to thank you who's been contributing to that, the people who are at the back, technicians and the interpreters and all the team that's been supporting to that. Thank you very much to all of you. And now from here, as I said, there is just lunch. So enjoy lunch, network, and thanks for coming to this session.